If you're using a CRP, regular CRP, as a cardiac marker for inflammation, and basically when it starts to get higher, particularly over 2 or 3, it loses its specificity, can you use it as a dual cardiac marker for inflammation for cancer?
I'd say yes. We use the we typically use the high sensitivity C-reactive protein. I don't know if anybody else can make comments about that, but there is a lot of literature on that particular marker and the outcomes in cancer when you target that to the normal level.
The second question is there any advantage or disadvantage of adding other supplements or nutrients to the IV vitamin C in the same IV?
That's going to be covered tomorrow morning during
I'll
a...
answer real briefly, just from my experience, because I won't be talking tomorrow morning. But obviously, alpha-lipoic acid, we have a paper in British Journal of Cancer showing that it potentiates the cytotoxic effects by quite a bit, by the most of any other nutrient that we screen. And then, of course, vitamin K, vitamin K2 and vitamin K3 also. And then anything that helps transport ascorbate into the membrane, transmembrane also potentiates.
You use just regular vitamins in there just to add them in that weren't necessarily facilitating the vitamin C? Would that interfere or have any advantage?
Which vitamins?
Like B vitamins
like
and
B vitamins.
magnesium, things like that.
Yeah, a lot of people do that already, but okay, yeah, sorry. I was going to say that bioflavonoids are probably the best transmembrane helpers of ascorbate, that from a dietary perspective.
Thank you.
I just have one quick comment about that. It does appear that the hydrogen peroxide is metabolized more quickly if you have B vitamins mixed in. And there was a paper that just recently came out to confirm that again. Sometimes when we work with people that are significantly behind the 8 ball on their nutritional status, we might start off with just giving them a little bit of a full spectrum, a more wide spectrum infusion, but then ultimately just get back to the IV vitamin C as much as we can. We try to keep it pretty pure and don't add too much stuff, just magnesium typically.
Yeah, we keep it pretty pure. I use it, and Dr. Ron, I know, uses it in patients that are very cachexic or where their B vitamins are very low, but we are also measuring those nutrients, so we have levels of those. But I use the B and the Myers in patients that are very undernourished in the beginning just to get their nourishment up, and I find it very helpful in that. But I've been told it's better not to use it, so it's kind of a decision you make, but from patient to patient.
Yeah, Gus Katsanis from Texas. I have a few questions. The first question to Dr. Riordan. I do IPT in my clinic, which is a low-dose chemotherapy, and of course vitamin C, mega doses. And there's a controversy.
I can't. It's vibrating so much I can't hear you. Did you say IPT?
Yes, I do IPT and I give vitamin C, different days or maybe the same day. So the question is, do you give vitamin C the same day of IPT or different days? There's a controversy. Give it right behind IPT or do it a different day?
Great question. I have no idea. Well, we had a lot of patients when I was practicing. We had a lot of patients, and we would always separate by at least 24 hours. We're just basing it off of the pharmacokinetic data that we had on the ascorbate, and within 24 hours, it would be down to normal physiologic levels, and that was whether they were going through radiotherapy or they're going through chemotherapy. Our goal was that they didn't go in there with a super physiologic level because we didn't know what was going to happen. So the only thing that we would do is we'd separate it by at least 24 hours because after, it doesn't matter how big the IV is, within 24 hours you're going to be below 10 milligrams per deciliter, but that's the best answer I've got.
Controversy is that some people say that if you do IPT, which is an accident event, and then right behind it, let's say you give 100 grams of vitamin C.
Which is
you s-
also an oxidative event.
Exactly. So they say don't mix them because they claim that vitamin C in high doses is an antioxidant, which we know it's not. So who's right?
No, his argument is that some people are saying you shouldn't give vitamin C, and this is the whole Gold article with prostate cancer. You know, his argument was, well, ascorbate is preferentially accumulated in prostate tumor tissue, so the last thing you want to give anybody with prostate cancer is vitamin C, because it's an antioxidant. If you're going to use a pro-oxidant therapy, then you don't want it there. So the other argument is, well, if you use it in a high enough dose and it does selectively concentrate, then you actually have a better chance at helping the pro-oxidative therapy to selectively destroy the tumor tissue. So great question. I don't have an answer. Does anybody else?
Doesn't Prasad say something about 24 hours?
Keter Prasad? I don't know.
Did
But
he say something about 24 hours?
Well, somebody
all I can
says
tell
give
you
it
is from
24
a
hours later.
PK standpoint, from a pharmacokinetic standpoint, at 24 hours, you're going to have a better level than you had yesterday prior to the IV, but it's not super physiologic. You might have 5 milligrams per deciliter. It's something that you could achieve orally, and you'll be back down to that level pretty much.
Well, we discussed here an oxidative stress. You want to increase it to kill if you want to use it to kill the cells, you want to use high dose vitamin C to do so. So some people say, well, if you do IPT, you've already done it, and then if you come right behind it and use the high dose vitamin C, it acts as an antioxidant, but it's not true.
This may just be anecdotal. I'd have to look up where this came from, but in communicating with some people that were trying to drive the glucose levels down using the insulin, they were able to follow that with the high-dose vitamin C, which somehow acted like glucose, and so they would have glucose levels of like 20, but no symptoms whatsoever. So I don't know if that would give you, support to maybe try to drive the glucose down, and then follow with the IV vitamin C, but I don't really know much about it personally.
Are you asking about whether to use IVC, when to use IVC if you're on chemotherapy, or the best route?
Yes.
Well, my understanding is the best time is to do it after chemotherapy, within 4 to 8 hours, because the vitamin C will help bring glucose into the cell, and cancer will readily take in the glucose as well as the vitamin C, so you're going to get more of the chemotherapy as well as the vitamin C into the cell if you do it within 4 to 8 hours after the chemotherapy. That's my understanding of it. So when patients are in chemotherapy, I always say try to come in that day you've had it, or at least one of the times that week if they're on once a week dosing, within 4 to 8 hours, because if you come 24 hours later, your plasma level is going to be back down to normal. I mean, higher than like what Neil said, but it's not going to help the chemotherapy, from my understanding. But anyone?
What were you talking about, insulin potentiation
Yeah.
therapy?
Do you want to talk?
Well, I didn't get it on the question, but insulin potentiation therapy, my understanding is that it opens up actually, vitamin C kills the cancer cells by extracellular accumulation. My understanding was that it lowered the blood glucose, but it also allowed vitamin C to get into the cell now, because the ports were open, the same ports that insulin used, that glucose uses, vitamin C uses, and therefore, there would be much more chemotherapy, in the cell,
The rest of the questions are much more simple. About aneuploid cells, whoever presented this morning said that there are 60 to 90 chromosomes in the cancer cells, from 43 to 90. So has anybody looked and see what are the other, whatever the number is, 30, 40 extra chromosomes? Is it a duplication of the human chromosomes? Is it a different type of chromosome, different DNA? What is it?
Yeah, they are human chromosomes. But you know what? The cool thing, I'm going to turn it around on you here, Gus. I'm 50. I'm just about 54 years old. If we pulled my cornea out right now, I've got all kinds of chromosomes. That I have cells in there that are worse than any tumor that you could pull out of anybody, right? So I just want to make that point, that in my cornea, I have cells that are not 46 chromosomes. I have cells that are 90 and 120 and everything else, and they're all human, right?
Human.
But they're not cancerous.
But they're your own chromosomes.
Yeah, everybody beyond a certain age, your cornea has these aberrations, but it never becomes cancerous.
Okay, and I have one more.
But I didn't answer your question. That was good. I should be a politician.
It's okay. No, you did.
We will reduce the budget deficit.
And how would you do that?
Yeah, exactly.
And photons. Last question.
Go ahead, just finish this up.
Yeah, on photons. Which foods have the most photons in it? Photons.
Photons.
The ones that are in the light.
The foods that are rich in photons.
You know, I don't know for sure, but I know that is one of the industrial applications of these biophoton monitoring devices. Is some of these big food companies will pick their fruit when the photons are at their maximum, the biophoton emissions. So then they know they'll have the longest shelf life for their food as they take it to market. I don't know. I mean, I don't think there's one variety that has. I can't answer it.
Okay.
I think just you want some rich, full color. But pretty much all the biophotons are in the visible light spectrum, which is pretty interesting, I think.
Thank you.
Dr. Hyman?
In treating cancer, there's a difference between response from the stem cell and the daughter cells. When we're using high-dose intravenous vitamin C, does it have effect on the stem cell of the cancer as well as the daughter cells?
Great question. Like your job. Well, we never studied that, so I don't know. I mean, the cancer stem cell post-dates my bench work on that, so, and I haven't read up on about it, but I will now.
Okay, thank you.
Oh, somebody got an answer.
Yeah. See, if the trophoblast is a true cancer cell, it comes from the stem cell producing a gametogenesis cell that then undergoes meiotic division, MEI, chromosome reduction to 23, because trophoblasts only have 23 chromosomes. And then these trophoblasts, then they all have different chromosome makeup, just like a sperm or an egg. No two of them have the same. So they're all different, but they're made from the same stem cell. It makes a gametogenesis cell, and then that produces the trophoblast. So they form multinucleated giant cells in the chorion, which is the outer layer of the pregnancy. They're produced lower down and produce these multinucleated giant cells, which if you studied them with their phenotype or their genotype would be more chromosomes maybe because they're multinucleated and it all gets mixed in together, I guess. But they're different. They're totally different from each other, just as a sperm or an egg is different. And they're the most primitive cell in the cell cycle. Now, they come from a stem cell that's only doing this according to trophoblast theory because it's finding itself in an environment that doesn't support oxygen respiration. And it's probably a thing of either go this way or die because the epithelial or whatever cell line it's producing can't live in this environment. It's too polluted with all kinds of stuff. It can't use oxygen. The only thing it can do is ferment. And so this cancer would come from that single stem cell that's reacting that way. And the multinucleated giant cells would explain cells with too many chromosomes or an abnormal number. Besides, in pregnancy, that abnormal chromosome numbers and everything happen quite frequently, in these, all this division going on.
The stem cell itself would be not dividing very often.
No, the stem cell will divide and replicate itself and at the same time produce a gametogenesis cell. It'll always replicate itself when it divides, but it'd probably divide into a bunch of duplicates in the beginning, just like it does in the fallopian tube. It forms a morula that doesn't differentiate until, say, after 2 or 3 days. Into the stem cells start differentiating into what they're going to produce. So maybe that explains the chromosome. And also, you know, if you looked at, it was at when you do the chromosome, those where they go up the little paper, what is it?
In telophase, you mean?
Yeah, you know how they all look like individuals. And another interesting thing is that in a molar pregnancy, the stem cells all the trophoblastic cells have only the male DNA in them. And they think that the male plays the male part of the pronucleus or of the contributor to the conceptus does more in the way of controlling what the trophoblasts do. Now they they produce this shell that hides the fetus from the mother's immune system. If it can do that successfully, for 9 months you birth a baby. So, you know, somehow cancer might be related to this. It's the trophoblast is the most primitive cell in the cell cycle. They all have different DNA, so it's going to look real confusing when you start pulling. It would look like a DNA sample from everybody in this room if you sampled the DNA out of the chorion. It'd look weird.
Okay.
Dr. Hyland, is there anything else you'd like to?
Well, there seemed to be, for the primitive stem cell, some protection against the pro-oxidant radical that can be in that area. What that coating might be, I'm not sure, but somehow it's being protected against the same thing that the daughter cells are not being protected. So I don't know how it gets there or how it's protected for sure.
The tissue inside the tumor, if it's made from that stem cell, is not going to be foreign to the body and is not going to elicit like the immune response. It's that tissue from that stem cell that's inside the tumor, like a hepatoma, like say increased cells. They really aren't malignant cells, according to my understanding. They're just abnormally produced cells, like the vessels in a tumor don't have any muscularis mucosa. So in radiology, if you want to see a tumor light up after you inject contrast, what you do is you put a little adrenaline into the artery first, very small amount. All of the normal vessels will clamp down, and you'll see that it'll look like a prune tree when you inject contrast, but not the tumor vessels. They'll just light up. It's a very low resistance vessel, and in the capillaries in the placenta, there are mother cells and trophoblast cells all mixed in together and working alongside one another in there. It's a complex thing. It's not understood too well, I don't think.
I think it was chorionic gonadotropin that was the shield.
Chorionic gonadotropin does, it shields, it reduces the immune response to whatever's inside this shell. And it's secreted by the trophoblast in tumors and in pregnancy, plus the antitryptic factors that block your peptic enzymes, because these peptic enzymes will digest this protein that's around the cancer, or I guess the fetus, because it's produced in pregnancy too, to bind these these enzymes up.
Well,
So,
if it is true, which I don't know that it is, if chorionic gonadotropin, is it secreted more by stem cells and less by the daughter cells? And
they
that
say in
makes
the
shield? I don't know.
current medical embryology book that it's a trophoblast production. The human chorionic gonadotropin is proportional to the number of trophoblasts. It's a trophoblastic hormone, and they isolate it from the trophoblasts, pull them out of the cell culture and look, and then that's where it's being made by the trophoblast. So when you see chorionic gonadotropin or a positive pregnancy test in a female that's not pregnant or a male that's certainly not pregnant, then you've got cancer somewhere in your body. They can detect it down to low levels.
Okay.
Thank you.
Thank you, Dr. Hyland. And this will be the last question for discussion. This is the last question. This will be the last question, and then the rest of the discussion will be informal after closing remarks. We have to close the meeting after this.
Understood. Michael Taylor, Tulsa, Oklahoma. I was just wondering here at Riordan Clinic if you have noticed or have done any research regarding intravenous vitamin C and reestablishing AMAS vigilance, anti-malignant antibody vigilance, whether or not it upregulates that under intravenous vitamin C. Has anybody done any noticed that at all?
I'll answer the best I can. The answer is no, but you know, the AMOS test was sort of all wildly popular at some point, and we actually wanted to do that, and we started sending samples, and they closed the lab, so we didn't get any data back. So that's when I was here. I don't know if anybody's done that. Is AMOS is it back up and running?
It's back.
Yeah.
I've noticed a few cases where we've reestablished anti-malignant antibody vigilance and with IVC patients. But I was just curious as to whether or not you guys might have noticed that, or if you've done any research on that.
Yeah.
So it was just an observation on my part. So.
Yeah.
Dr. Ron could probably answer that better than I could. We haven't been doing, we've had several patients ask for the test, and we have done the test, but I'm
once the
not sure
cancer is
about
well
it.
established, the antigen suppresses the antibody, and so it's a worthless test. But once you get ahead of it, the antibody reestablishes, or at least from what I've seen, and that's what thought I'd ask.
I can't comment on that. Dr. Ron or Dr. Henshaw here might be able to answer that question.
Talk
Yeah, after.
Yeah.
Okay, thank you.
So, I'd like to thank our panelists for today, Dr. Riordan and Dr. Bauerschmidt and Sullivan and Kaumeyer and Wassell. Thank you for today.